So in the last section, section 7, we're going to be talking about stroke volume, heart rate, and cardiac output. So regulation of pumping is going to involve our heart's ability to adjust our output based off of whatever our body's needs are at that time. And when we're talking about cardiac output, we're referring to the volume of blood that each ventricle pumps per minute, and it's calculated as heart rate times stroke volume. So at rest, our average heart rate is 75 beats per minute. This number might sound familiar because that was the same times per minute that our SA nodes spontaneously depolarized. And at rest, our stroke volume is about 70 milliliters per beat. So if we took our heart rate of 75, multiplied it by our stroke volume of 70, converted the milliliters, because this is in milliliters, to liters, we would get a cardiac output of about 5.25 liters per minute. Well, if you happen to know our entire blood volume, it's around 5 liters. So we're actually pumping our entire blood volume plus more every minute. So it's actually pretty impressive. So if we are a non-athletic individual, our maximal cardiac output can increase about 4 to 5 times during exercise. If we're a trained athlete, we're going to have significantly more, up to 35 liters per minute. Cardiac reserve is just the difference between our resting and our maximal output. But the important thing is that our cardiac output can fluctuate if we change any one of the components. If we change heart rate, if we change stroke volume, or if we change both. So stroke volume is calculated as end diastolic volume minus end systolic volume. So if you remember me saying previously, it's really important to understand and recognize what these terms represent. So just as a refresher, your end diastolic volume is the maximum amount of blood you have in the ventricles before they contract. Your end systolic volume is how much is left in your ventricles after they contract. So if you take your max amount that you have in your ventricles and subtract what's left in the ventricles after contraction, it's telling you how much you actually pumped out of your ventricle. And that's what stroke volume represents. So a normal stroke volume, like I mentioned, is about 70 milliliters per beat. And there's 3 key factors that influence stroke volume, and that's preload, contractility, and afterload. So make sure you understand what these all mean. So preload is really referring to the stretchiness of cardiac muscle cells before contraction, and it's going to be influenced by how much blood we're actually returning to the heart, which is referred to as venous return. So the greater the preload, that's going to lead to a stronger contraction, and this relationship is described by the Frank-Starling law of the heart. So exercise and slower heartbeats can increase our venous return. This is going to boost our preload and our end diastolic volume, and thus our stroke volume and our cardiac output. So that's kind of what it's showing you here. We're increasing the amount of venous return, or the amount of blood we are bringing back to our heart. If we increase the amount of blood we're bringing back to our heart, that means we're going to increase the amount of blood we have in our ventricles. So we increase the end diastolic volume. The more blood that we have in our ventricles before contraction, the more we're going to be able to push out during contraction. So we're going to increase our stroke volume as well. So the relationship between the EDV and the SV is what's referred to as the Frank-Starling law. If we increase our stroke volume, we're going to increase our cardiac output, because cardiac output is equal to heart rate times stroke volume. The second factor that can affect stroke volume is going to be contractility. And this is how much force do we have with our contraction at a given muscle length. And this is completely independent of the preload or the stretchiness or of end diastolic volume. We can enhance contractility by sympathetic stimulation. Epinephrine is really going to play the largest role here. And epinephrine's role is going to be to increase calcium availability, so we can increase the number of cross bridges that we form. So we have what are referred to as positive inotropic agents, so things like thyroxine, glucagon, and digitalis. These are going to also enhance contractility. And then we have negative inotropic agents like acidosis, elevated potassium levels, or calcium channel blockers. So these things would weaken our contractility. So greater contractility is going to lower our end systolic volume, leading to an increase in our stroke volume. This is showing you norepinephrine or epinephrine's role in contractility. I would kind of have a general idea of what's going on here. So we have norepinephrine that binds to the receptors on the heart. If you remember from AMP1, epinephrine and norepinephrine bind adrenergic receptors. The type of adrenergic receptor that's on the surface of the heart is the beta-1 adrenergic receptor. So norepinephrine binds to the beta-1 adrenergic receptor, and it's going to initiate a second messenger system. So you learned previously about one second messenger system that uses ATP. This one's going to use GTP. So we have GTP that's basically going to translocate. That's not as important. What's important is that we're going to get adenylate cyclase activated, which is going to cause ATP to become cyclic in form. When ATP becomes cyclic in form, it's going to form cyclic AMP, which is referred to as CAMP. CAMP goes on to activate a protein kinase. A kinase is just an enzyme that goes on to phosphorylate something. So in this case, our active protein kinase, which is our second messenger in the second messenger system, is going to go on to phosphorylate two really important things. One of which are going to be the calcium channels in the sarcoplasmic reticulum, and the other one are going to be the calcium channels in the plasma membrane. So we mentioned the importance of calcium in any type of contraction, and we also talked about how cardiac muscle cells have two sources of calcium, one from the sarcoplasmic reticulum and one from the extracellular space. So how do we get this calcium needed for contraction? It's actually from norepinephrine binding. So the third thing that can affect and influence stroke volume is going to be afterload. And afterload is the pressure that the ventricles have to overcome in order to eject its blood. So we have pressure in our arterial blood and our pulmonary trunk. We have to make sure the pressure is greater than that in order to get blood from our ventricles out into these arteries. The aortic pressure is about 80 millimeters of mercury, and the pulmonary pressure that we have to overcome is about 10 millimeters of mercury. If you have hypertension, this usually is going to increase the afterload, and it's going to make it a lot harder for our ventricles to eject blood, which is going to raise our end systolic volume and decrease our stroke volume. When our stroke volume drops due to some sort of low blood volume or weakened contraction, our cardiac output can be maintained by increasing our heart rate and contractility. And this is going to be managed through regulation of our heart rate via the autonomic nervous system, some chemicals, as well as some other factors. So the sympathetic nervous system accelerates our heart rate in response to any sort of emotional or physical stress. How does it do that? It's going to release norepinephrine, which we just talked about, that's going to go on to bind the beta-1 adrenergic receptors on the heart. So this is going to speed up the SA node, it's going to increase contractility, and it's going to lower our end systolic volume. Meanwhile, our parasympathetic nervous system, via the vagus nerve, is going to basically counter this with acetylcholine, which is going to act to slow the heart rate by opening potassium channels in those pacemaker cells. So this system is actually dominant at rest, maintaining what we refer to as the vagal tone that helps keep our heart rate at about 25 beats per minute lower than what it would be without it. So a unique response is referred to as the Bainbridge reflex, also referred to as the atrial reflex, and this is going to be triggered by increased venous return. So the more blood we have coming back to the heart, the more we're going to stretch our atrial walls. And this is going to stimulate the SA node and the sympathetic centers to increase our heart rate. And this is going to help maintain balance between venous return and output. So this is a really good flow chart kind of everything that we've talked about and how we can act or things that we can do in order to increase our cardiac output. I also recommend you understand things that would happen if we would lower our cardiac output. So for lowering our cardiac output, that would be things like lowering the amount of blood we have returning to the heart or lowering the venous return. Lowering contractility would mean that we would lower our stroke volume, which means we would lower our cardiac output. So kind of understand what's going on, both to increase cardiac output and to decrease cardiac output. So chemical regulation of the heart is going to involve hormones like epinephrine that we talked about from the adrenal medulla and thyroxine, both of which can increase heart rate and contractility. We also have ion concentrations, especially that of calcium and potassium. These have to be carefully balanced. If we have any imbalances, it can be really dangerous and it can disrupt our cardiac rhythm and function. Other factors can also influence heart rate, like age. Our fetal heart rate is going to be the fastest. The older you are, the slower your heart rate is. Also gender, so females usually have a faster heart rate than males. Exercise, again, this can increase heart rate, but it is short term. Long term, it actually lowers your resting heart rate, especially in really athletic people. Body temperature also plays a role, so higher temperatures are going to increase your heart rate. So congestive heart failure is a progressive condition where the heart can't pump effectively enough to meet our body's needs. So there's different causes. Causes are going to include coronary atherosclerosis, which means we have fat-clogged arteries that starve the heart of oxygen. High blood pressure can also play a role, requiring some extra effort from our myocardium because we have some damage. We can also have multiple heart attacks, which create scar tissue, and dilated cardiomyopathy or DCM. This is when our ventricles are stretched and weakened. So congestive heart failure can affect either side of the heart. If we have left-sided heart failure, this is going to lead to pulmonary congestion because we're going to have bad blood backing up into our lungs. If we have right side heart failure, this is going to cause peripheral congestion, leading to fluid buildup and swelling in our tissues or edema. Failure on one side can quickly burden and weaken the other one, potentially resulting in a total heart failure. So treatments usually include making sure we remove excess fluid and using medications to help reduce the afterload and boost contractility.